Chara Reid, Manager of Pharmacy Services at Dupage Medical Group in Illinois, will now deliver our Clinical Corner presentation sponsored by Genentech. This month's Clinical Corner presentation is on Venclexta for AML. Chara.
Thanks, Stephen. So today we're going to talk about Venclexta and AML. I have 10 minutes, so I'm going to try to go through this quickly. And of course, any questions you have, please just type them through, and if I can't answer them, I can get back to you. Our objectives today are to identify the key differences between the treatment of AML and CLL with Venclexta, recognize common adverse effects and drug interactions in patients being treated with Venclexta, and to formulate a treatment plan, including Venclexta in patients with AML. I will say this talk is not about CLL, but because I know there's the dosing is vastly different between treating AML and CLL. It was important when I was putting these slides together and talking to Genentech and my MSL, they as an organization really want to make sure that we're highlighting the differences, even though we're not talking about treating AML or treating CLL. So in AML, it's a cancer of the hematopoietic precursor cells, interferes with normal production of blood cells, often leading to genetic mutations in the immature precursor cells, and AML is the most common acute leukemia in adults and does account for 1% of cancer deaths in the U.S. Patients generally present with anemia, pale skin, bruising, headache. The diagnosis does require a bone marrow biopsy. So looking at AML, these hematopoietic cell transplant is typically what, is kind of our first line of treatment for these patients. But for various reasons, some patients are not eligible for a transplant. One can be over the age of 75, a low forced vital capacity, also a low serum creatinine or low creatinine clearance, or a low ejection fraction. So these patients aren't eligible for our first line therapy of a cell transplant. And the eligibility for patients who are eligible or not eligible for cell transplant, it's various. So there's just not one single marker we look at. The physician will make those decisions based on various factors listed. So Venclexta, it's indicated in the treatment of newly diagnosed AML with azacitidine, decitabine, or low-dose cytarabine in patients over the age of 75 or with various other comorbidities that preclude us from using intensive reduction therapy. Prior to initiation, we do want to check those white blood counts. And it's very, very important that these patients get pre-medicated with hydration in the infusion setting, just so we can help reduce that risk of TLS in these patients. So the Venclexta mechanism of action, it inhibits BCL2, leading to tumor cell apoptosis. The BCL2 is overexpressed in AML, and so that overexpression allows the cancer cells to evade apoptosis, and Venclexta binds selectively to BCL2, freeing up those pro-apoptotic proteins that initiate the programming of the cell death. So therefore, it's inhibiting the Venclexta inhibits that apoptosis, or helps with that apoptosis. So there were, in the interest of time, I didn't have time to go over both the two different clinical trials. So I'm focusing on the clinical trial that got Venclexta approved in a phase 1/2 study, and it was used in low dose cytarabine. But just to be aware, there is another study that did approve it to be used in the azacitidine and the decitabine treatment arm. So there are various doses. We will highlight that, but for time's sake, I won't go through the both arms of that study. So this study had a population of patients were greater than or equal to the age of 65 with previously untreated AML, and they were ineligible for standard induction therapy and had an ECOG of 0 to 2. The treatment arm looked at actually 3 different doses of Venclexta plus cytarabine. They looked at 400 milligrams, 600 milligrams, and 800 milligram arm. I will say that the dose that came out in the FDA guidelines is the 600 milligrams. So for if a patient's getting cytarabine, so we're not definitely not using 800 milligrams, and 400 milligrams is only approved in another treatment arm, and I'll talk about that here in a second. The primary endpoint was safety, dose-limiting toxicities, and kinetic markers. So one of the important things that shook out in this trial, which got it approved so quickly, was that there was a really short time to response. So in these patients, the median time to response was 1 month, and the median time to best response was 2.6, so 2.5 months. So that's actually, you know, unusual that we get a drug that works so quickly in this AML setting. And if you look at the patients who got a response, at the top of the slide is the total response rate. So these patients of all patients, 62% of patients responded. If you split out the intermediate risk patients and the high risk patients, the high risk patients responded at a 76% rate as opposed to a 47% rate. But so it's still a really good rate of response for these patients. And there's a breakdown there of a partial response, a complete response, which actually rendered these patients, they didn't have to get a transplant. And then there was a partial response. So they were in remission, but not with the total, they were in incomplete bone recovery. Moving to the next slide. The other important thing about the medication is they looked at patients who had mutations, if there was a difference, if a patient had a FLT3 mutation or IDH1/2 mutation, and after the end of the trial, they noticed that it did not matter. It was mutation agnostic who responded. So it didn't matter if the patients had the mutations or not, the FLT3 or IDH1/2, they still responded to drug. And you can see here, there's a slide here that shows those response rates, and the duration of response has actually not even been reached yet. So moving, next slide. So we're going to go over the adverse reactions with the Venclexta 600 milligrams. It is a small subset of patients here. The N was only 61. You know, the most common side effects are the nausea, the hypokalemia, the fatigue, the diarrhea. But if you look at the total, we only listed on the slide any of the grade patients who had all grades greater than 30% is what I included. So just the top reactions, and I would just, you know, tell providers and practitioners to treat these patients according to your practice guidelines based on what you would normally do for any of these drug interactions for an oral medication. So the management of drug interactions, it's important. If you look at the red, those are the CLL/SLL. These drugs are actually, the CYP3 inhibitors are contraindicated if patients have the CLL or SLL diagnosis. So we put that in, even though that's not, you know, the point of our topic today. In AML, you actually can use these CYP3 inhibitors. You just have to dose reduce. So it's important to understand, though, that is a different indication than if you're treating CLL. And CLL, these CYP3 inhibitors are actually contraindicated, and we would not use them with Venclexta. If the patient has a moderate CYP3A or PGP inhibitor, you can reduce the Venclexta dose by 50%. So Venclexta dosing, at the top, it's a different ramp up in AML versus CLL. So you're going to start at 1 tablet on day 1, 2 on day 2, 4 on day 3. If they're getting azacitidine or decitabine, they'll end up at 400 milligrams daily. If they're in the low dose cytarabine treatment, then they'll get 600 milligrams per day. But just remember that ramp up is only 3 days in AML, very, very different than CLL. CLL has a 5-week ramp up, and I just want to be sure that nobody mixes that up. Next slide. And then we added a slide here because Genentech has really generous financial support programs for patients. I saw something, I think yesterday, on a patient that was having a hard time getting their Venclexta approved. Genentech can work with you, and we did list those websites, so you can use those in helping patients decrease the cost or look for free drug or foundation assistance. The organization will help with that. Last takeaway points, the treatment differences between AML versus CLL is there are definite differences in the drug interaction dose adjustments and the up titration of dosing. So just keep that in mind, that they're very different depending on what you're treating. Really important that kind of sets Venclexta aside is that there's a short median response to time, 1 month versus 4 months in some of the other traditional orals. And the response indicates a greater portion of patients that may become transfusion independent. So, and the treatment response is independent of genetic mutations. And any questions?
Great, Chara, thanks. So we'll open it up to our members. Remember, please feel free to enter any questions or comments in the Q&A or chat box. So we'll pause for a moment. And also did want to mention that NCODA also has some financial assistance information regarding Venclexta on our website under the financial assistance tab. So Chara, it looks like we did have a question come in. The question reads, can you speak briefly on your experience with Venclexta and patient response, if applicable?
Yeah, so I will tell you, we have a couple patients on Venclexta right now, and I know there was kind of a big worry about TLS, and not that we don't discount that, but we haven't seen it. So I don't know if that's answering the person's question, but our patients are doing, our 2 patients who are on drug are doing actually really well, and right now, I don't have any patients who we treated with AML. These were patients in the CLL. We did their dose ramp up, and they were fine.
Thanks, Chara.
We did obviously monitor them appropriately, but no issues.
Okay. And we did have another comment come in, and a member wanted to know if these slides would be made accessible to our members. While the slide deck themselves, no, feel free to visit our YouTube and Vimeo channels and the NCODA website, as we will post these specific presentations that you can go and take a look back on, so you can view the slides and the recording. So Chara, thank you so much.